Hi friends, I want to share with you some helpful information to perform your final project together. You're going to be on ethics committee teams. I'm going to give you actual ethics dilemmas from Harborview Hospital, and to do so I'm going to share with you some information given to me by Dr. Diane Timberlake, who has visited my class many times in person and helped my class arm them, I guess, with some ways of seeing cases and ways of charting them to make sure they're doing the best job they can to flesh out the complexity of these hard situations. Here are Dr. Timberlake's guidelines in your resources segment here. Let's open these up. I'll enlarge these for us and talk about them a little bit. The first principle that Harborview Hospital wants to respect is the autonomy or the self-determination of each individual patient. It's a perennial value in our whole culture, but in hospitals sometimes we have people whose, as you can imagine, whose will or whose hopes are not knowable, and so that can make it a little complex. Second is the principle of doing no harm. It's a Hippocratic element here: to avoid, prevent, remove harm proportional to the treatment goals. That's sometimes difficult to know what is the most harmful or the least harmful course of treatment. And beneficence is the general theory that we want to do what's beneficial to the patient. Although notice here she points out we have to think of what is beneficial from the patient's point of view. We don't want to impose what we doctors consider to be what a patient ought to value. We want to think of things, some are religious, some are not, some are tired and aged, and some are young with young families. The patient's point of view matters a lot in terms of what would be beneficial to them. Justice is an interesting principle here because they want to be sure they're distributing healthcare benefits fairly. For example, they don't want to discount treatment for a person because of their inability to pay. Likewise, they don't want to treat a person over and over again futilely at great expense when that resource could be shared elsewhere. So justice is an interesting dynamic here. Truthfulness refers to their hope to be transparent and informed with their patients, to really give them the full picture of what their treatment options are, the pros and cons and all that kind of a thing. So with these general principles, and you'll probably refer to these in your summary of your case, all the actions will kind of depend on the way those flesh out. Now here is a second piece that I think is interesting, is she and her fellow physicians like to build a chart, and it's just a big whiteboard around a table that they all sit and they talk about, and these four quadrants are all important. The first of the medical indications. By that we just mean, what are the various ailments of the patient? Perhaps the patients come in with a automobile accident and they have certain injuries. That would be the starting place, the broken leg or the fractured skull or whatever. But this may be in addition to other things. Perhaps in addition to that we have a diabetic person or an aged person, or who knows what else. So we want to get our hand around the whole, our heads I should say, around the entire picture of the medical conditions, as well as the most urgent one that we plan to treat. And that helps us to understand how likely it is that we could achieve our treatment goals. Second, and not necessarily second, these could be in any order, we want to know what the patient preferences are. If the patient has expressed preferences for treatment. We've seen this before in the Terry Schiavo case. We didn't know what her treatment preferences were. Some patients have living wills, and in which they give very specific directions for what they want done at the end of their lives. Maybe they have the capacity to decide now. Maybe they don't have that, but they're coherent. If they're not, though, and there is no living will or advance directive, who's to decide for the patient? Is it a wife, a child? If they don't have anybody and we don't know a family member, sometimes an ad litem surrogate is appointed to do the deciding for them. And do the patient's wishes reflect a process that's informed? Are they clear about their choices and the risks and so on? And do the physicians feel the patient is voluntarily choosing this, or can the physicians feel that perhaps a patient is under some pressure to choose one way or another inauthentically? The quality of life questions, we're talking about the expectation, not just the current quality of life, but the expectation of a patient's quality of life if we do treat and if we don't treat. Is the patient present or future conditions such that continued life might be judged undesirable? Are there biases that might prejudice our healthcare providing? Do we have an attitude, perhaps, if this patient is homeless, that maybe they don't want to be treated, which we have to be careful of? Who are we to say that's true because of their circumstances? So our own biases, we have to be just cautious, I guess, that we're not having our decisions clouded by those. Contextual features are other interesting things. Sometimes there are family issues that might influence a treatment decision. Perhaps a patient wants treatment and the family does not want it for them, or more likely the patient does not want treatment and the family really does. Perhaps there are financial issues. Perhaps the patient would have nobody at home to care for them if they were to do some extended treatments of some kind. Maybe there are societal or cultural issues. Maybe this is a family that does not want certain treatments based on religious beliefs. That would be a contextual feature. Maybe there are legal issues about our treatment decisions. So if there are any contextual, there are always some. What are the contextual features that, this particular case is different from another one with the same medical condition because of the contextual features, if you see what I mean. So with these in place, with these general philosophies above, and these 4 quadrants, which you and your partner will fill out according to your case, you should be able to have enough information to arrive at a conclusion. And that's the hope of this time together, that you and your partner will achieve a conclusion together. So I'll close this and show you what we'll have next. Once you guys read that, and you'll have these actual ethics cases. I'll show you briefly here. Here are 4 cases I've gleaned from a number of them. Number 1, Mr. J, 79-year-old man. Mrs. A, 29-year-old woman, very young. Mr. G, a 70-year-old non-English speaking Greek man. And Mr. B, at last, 52-year-old male, sad case. He had attempted a suicide. This one, Mr. G, has diabetes and a lot of infections in his feet and legs. And up here we have a woman who has breast cancer, but who is suspicious that hospitals are what gave her cancer, and she is not open to treatment. And here we have a case of a man who had an advance directive and some complicated conditions, but his family disagrees and hopes for him to have treatment, even though he has expressed a disinterest in that. So I think you'll find these cases really compelling and, of course, complex. If they were easy, they wouldn't be here. You're also going to notice some vocabulary issues in here. This is actual medical speak, and sometimes you'll want to look up what these mean. This person has a large LMCA CVA. Well, what the heck is that? I recommend to you in your directions, Google them. If you Google medical MCA, for example, you will find middle cerebral artery stroke. And so you can just look these up as I did and find out L obviously would be left. What the heck is hemiplegia? We'll look it up and you will know what you're talking about. So I don't think there's anything within these that I was not able to find pretty quickly by looking it up myself. So that being said, away you go and enjoy these cases. I hope you will. And the timeline for this, I can show you here in our, whoops, I'm going to expose this for you to see now. I've been hiding it from you. The timeline for this is here. We'll look at this case analysis. My recommendation is that by 424 you will have seen this screencast and read your cases. By 425 you will have typed out your own chart of information on the 4-quadrant system so you can share it with your partner. You'll each do 2 cases. By 426 you're going to spend time with your partner fleshing out all the considerations and the ethical rationales. Now each of you is only going to produce a presentation for one of these cases. You're just going to use each other for helpful input. By 428 you will have your personal screencast ready to share with your partner for polishing ideas. And by 4:30 you will submit your final screencast to me. Okay? Directions are here. I wish you luck. And I really look forward to this final effort of your collaboration with your partner. All right, take care.